So good morning, everyone. Good morning,
Good morning. Good morning.
panelists, speakers, and everyone who has joined us to the first virtual Radiotheranostics Summit organized by Oncidium Foundation and Medicaid Foundation. So this is the first of a three-part series of webinars that we'll be having in the month of August. Let me see. Okay, I'm just going to share my screen. Okay, just a few housekeeping before we go into our presentation. If you have questions and answers, please put them in the chat box and we will take them at the end of the presentation. This webinar, those who attend this webinar are entitled to receive a certificate of attendance. And at the end of the meeting, we will tell us where to send an email if you would like to receive a certificate of attendance. Okay, just a brief introduction. I'm Iyobosa Uwadiae. I'm a board-certified medical physicist and also the president of the Nigerian Association of Medical Physicists, and I'll be your moderator for the 3 sessions in this webinar series. So I'll quickly like to introduce the 2 organizers, the 2 companies or organizations responsible for organizing this summit. The Oncidium Foundation is an independent non-profit organization committed to advancing radiotheranostics for cancer care worldwide. And they do this through education and awareness, access to treatment. They provide access to treatment donation for patients in regions where the treatment is not reimbursed yet through RLT Connect. And they also are involved in a lot of advocacy, providing equitable access to cutting-edge cancer treatments wherever patients live. The second organization, the Medicaid Foundation, is based in Nigeria, founded by Her Excellency Dr. Zainab Shikafi Bagudu, is also an official partner and a Nigerian-based nonprofit committed to the fight against cancer through awareness, early detection, patient support, and advocacy. So MCF has been at the forefront of driving cancer conversations across Nigeria and the wider African continent, working to close gaps in access, education, and care. They operate as part of a larger group, the Medicaid group, alongside Radiodiagnostics clinic. They have a pharmacy, and they do this together to bring advocacy, diagnosis, and treatment support under one mission, which is a future where cancer is detected early, treated effectively, and no longer carries the weight of silence or stigma. So these 2 foundations have come together to organize this webinar series to answer the question of how can Nigeria, and I want to believe the other countries in the region too, how can we turn the scientific promise of radiotheranostics into real access for patients? So I mentioned earlier that this is the first part of a 3-part series. Today we'll be looking at the science of radiotheranostics, and then next week and the week after we'll have other guests who will give us perspectives from the global community. And then we will now look into how we can implement all what we will discuss in the next 2 weeks, how we can implement them in Nigeria, and hopefully that would extend to other countries. Other countries in the region can also learn from that. So our agenda today, we have 2 speakers. I will introduce them shortly. Dr. Kolade Mayowa and Dr. Akintunde Orunmuyi. If you look at the screen, they will be speaking in this order. Dr. Kolade will introduce us to the science of radiotheranostics, and then Dr. Akin will tell us how to make it work in our client. And then Dr. Mayowa will end by telling us the clinical applications and treatment workflow, and after which we'll take your questions. So Dr. Kolade Mayowa is a consultant nuclear medicine physician and also the clinical director, molecular imaging and theranostics at the University College Hospital, Ibadan. I've been privileged to work with both speakers today. So he's a triple fellow in nuclear medicine in South Africa, European Board, and the Royal College of Physicians, London. He led the team that established the first Tuition 177 PSME and DOTA-TATE radioligand therapy service in Nigeria. This happened at University College Hospital. And our next speaker, Dr. Akintunde Orunmuyi, is also a nuclear medicine consultant, currently at the University Hospital, Southampton NHS Foundation. Before moving to the UK, he also worked here in Nigeria, so he has a lot of experience here at the University College Hospital and even within Africa. And is the ambassador for the Oncidium Foundation. So today we'll be covering, this will be our objectives today. We'll look at radiotheranostics and its role in precision medicine, the mechanisms of targeting ligands, receptors, radiotracers, diagnostic therapeutic pairing and treatment workflows, clinical applications, safety dosimetry, and the relevance to Nigeria's cancer burden and care pathways. So please, if you have questions while they speak, you can please put your questions in the chat and we'll take them immediately after they are done with their presentation. So without further ado, I would like to introduce Dr. Kolade Mayowa, who will be speaking first, after which we would have Dr. Orunmuyi. So Dr. Kolade, thank you for being our honorable guest on the first virtual radiotheranostics series in the country. Can you please share your
Thank
screen?
you, Dr. Iyobosa.
Yeah.
Good afternoon, morning, evening, depending on where you're joining from across the globe. Just a quick check that you can see my slides and you can hear me.
We can hear you, but we can't see the slides yet.
Okay, so I will stop sharing and start sharing again.
All right.
Okay. Right, so let's give
Dr.
this.
Kolade will be speaking for 15 minutes. And then we'll move over to Dr. Akrim. Okay, yeah, we can see your screen.
All right. Perfect. All right, I would shoot. Good afternoon, everyone, ladies, gentlemen, colleagues, distinguished guests from around.
Sorry to interrupt, Dr.
Okay.
Kolade. We are not seeing your slide. We were seeing before, but not now.
I think it's just a lag. You can continue. Your slides are visible here.
Yeah, we can see. Yeah. Please go ahead. Yeah.
Okay. All right. So I think we're in for a very exciting set of discussions today. It's really revolutionary stuff. And before we go ahead, I just want to mention that the Oncidium Foundation, to whom we're very grateful, supported 6 out of 37 of our doses, and they are co-organizers for this summit. So it's important I say that, and I'm an Oncidium ambassador as well. Aside that, I have no other conflicts of interest, except the fact that I really love nuclear medicine. And I have ulterior motives to make you a convert today. So we speak about precision medicine. Why we say that is because many times with cancer care, what we do is almost like shooting an arrow into a dark room. We sort of target it in the direction where it should go, but we don't have too many certainties. Unlike many other cancer therapies, theranostics is guided. And the word you'd hear a lot today is theranostics. Familiar to some, strange to others, but will be known by all today. It's simply an amalgamation of two words, therapy and diagnostics, or like I like to say, it's diagnostics and therapy because that's the order in which it happens. Think about this with me. If I went to your house or your office complex and you didn't want to tell me where your room was or which was your room, without telling me your room, if you gave me your key and I tried it across the rooms in the house, the one that opens will certainly be your room without you telling me which is yours. Therefore, with cancers, they have a lock and key system somewhat, and it's not just an analogy. This is a cartoon that shows the prostate gland. The purple part indicates a cancerous lesion. And if we're to look at it at the molecular level, there are receptors that go through the membrane of the prostate cancer cell, hence the name prostate-specific membrane antigen. And the antigens and antibody systems work like locks and keys. So the lock and key, imagine we attached a light bulb to it. So wherever the light bulb glows is where the key goes, or where the key goes is where the light glows. And that same way, we're able to use this system of radioligands to detect prostate cancer. We don't only see that they're there, but we could swap out the light bulb for a very tiny, powerful radioactive element that destroys the cancer cell, doesn't travel too far to destroy neighboring cells, and also shines a light. So where the light shines is where the bomb blows. With this simple lock and key system, we're able to look at disease, not just where it is present in structures that are apparent, but in structures where it may not be so apparent as well. We have a set of tools where we can see the cancer and then we take out the light bulb, replace it with a tiny and powerful radioactive missile, so to say, to use to treat it. And here we, for the first time amongst systemic cancer therapies, can take pictures of where the drug will go to. And before the first therapeutic dose is administered, we know if it will work or not. Here is a picture from one of our patients. It's anonymized. It shows many dark spots. Think about those dark spots as sites where prostate cancer is present in the patient. Here is another one of these patients. You can see that the dark spots are present, but in colloquial terms, we say it's darker than the other one. And this is a very important core principle in theranostics. It's essentially that what we see is what we treat. We don't just look to see that it's there. We want to see that it's there in sufficient amounts. There are ways we check this that I won't bore you with today, but it's important that it's not just there, but it's there sufficiently, because again, where the light glows is where the bomb goes. We treat what we see. And it's a very important biomarker, because what is seen is what is treated. If you don't see it so well, you probably wouldn't treat it so well. And this is the treatment scan for this patient, where you can see essentially the areas you see on the left image, which was the diagnostic image, were essentially seen on the right side, which is a therapeutic image. A bit of the science of it. Radioligands, what I try to conceptualize with the lock and key with the light bulb attached, is not that simple, but in a sense, it's simple again, because the things we want something that acts like a key that fits into a lock. That's the targeting area. We want something that's like a cage that holds the bomb to make sure it gets to where it should be delivered. That's the chelator. And a couple of other scientific things around I don't want to bore our audience with, but very centrally is the payload, and I'll get to talk about this very shortly. Now, this targeting vector is currently clinically used routinely across 3 types of cancers, 2 and 1 has existed for quite a while. And I'll show them to us here, essentially just re-emphasizing the fact that we have tools to see them, and we have the other set of tools, that's the other end of the pair, to treat them, and hence the concept of theranostics. These first 3 are routinely used in clinical care, and this is not just textbook stuff. This is routine care that happens in our hospital here in Ibadan, Nigeria. The third is one that's a bit on out on the horizon for us, and before the end of this year, we hope to be involved in the clinical trials for this agent. So just watch out for it, lutetium FAP. The FAP target is what that's about. And that's exciting because it's pan-tumoral. Right now, our theranostic efforts are largely around metastatic prostate cancer, neuroendocrine tumors, and thyroid cancer. But this will be pan-tumoral, so we could, influence much more outcomes with this tool. As regards the payload that I talked to you about earlier, right now you'd hear us talk about lutetium-177 PSMA, lutetium-177 dotatate. You hear lutetium-177 a lot. The reason is that this is our workhorse, and it's our workhorse for many reasons, but 2 reasons chiefly. One is the path length, so how far it travels in tissue. It travels about 0.5 to 2 millimeters in tissue, and that's about, on the average, between 40 to 200 cells. This is very important because sometimes tumors are very heterogeneous. Not every single tumor would express the lock and key exceptionally well to make sure the payload gets there. But if it's lutetium-177 that's being used, if a neighboring cell has enough of a lock and key system to get it delivered, there is a phenomenon called the crossfire. That's again because of the path length. So it's very forgiving when you don't have the best targets, so to say. The other 2 on your screen, alphas. Alphas are very powerful. They travel very short lengths, so they're very useful, and they'll increasingly be showing up on the clinical landscape, where we are looking at treating micrometastases. So we don't want to treat anything that's more than 2 to 10 cell diameters. That is very powerful, but it's not as forgiving. And because it's not as forgiving, you want to be careful with using them. The third is one that I think you're going to be hearing about very shortly, very soon, and locally as well. It's terbium-161. And this is a payload that has a component that behaves like lutetium, but has Auger, which is a type of radioactive emission that only travels a very, very short distance. So that's again going to be excellent for micrometastases, and you would be seeing this in the clinical landscape. What I believe is the future is that we're going to be combining these agents, and it's already happening. We call them tandem therapies, where we use one and the other because of what we're trying to achieve in the patient. And this becomes very important in prostate cancer in particular, where there are patients who could have a lot of bone marrow disease. Now, crossfire is a benefit when you have heterogeneous tumors, but crossfire is probably not a benefit when the crossfire is going to be affecting blood-producing cells, which is what the bone marrow chiefly does. So in this circumstance, we could treat patients with very, very keen precision with alphas, maybe with Augers, and spare bone marrow, because bone marrow toxicity is one of the biggest things that gets us to stop treating patients, especially in patients who have had lots of treatment before coming to us in nuclear medicine. So here is what one cycle of one theranostic cycle entails. I've told you about the diagnostic part and the therapeutic part. So blocks 1 and 4 essentially capture the see it and treat it paradigm. But in between that and around that, a lot else happens. The surgeons and the urologists and the endocrinologists and pain management teams, we all come together to make decisions about our patients. And that's very important. After they're treated by us, which will be blocks 3, 4, and 5, which essentially are the points that sit in the nuclear medicine department, and they are discharged, they continue to follow up with the oncologist. So this is not nuclear medicine taking over people's patients. It's a greater call to greater teamwork. We are going to be talking much more and crisscrossing much more. But here's what I really want to point out in this slide, is that 1 and 4, which is the core science of theranostics, is not where most of our patients have issues. Most of our patients have issues in the other blocks, which I like to refer to as real life. The science is great, but real life is where the Nigerian patient often gets stuck. They get stuck where the MDT decides that this patient is best served with lutetium-177 PSMA. But the patient is not fit. The patient has had lots and lots of pre-treatment, lots of taxane-based chemotherapy, external beam radiotherapy, and they need a lot of time to recover. Or the patient is fit and lives just 100 kilometers away in Lagos, the popular city for those who are joining from outside the country, and can easily travel down to Ibadan. Unfortunately, he travels down so he can access it, but he can't afford it. That's where real life happens. Or the patient has had therapy and doesn't have the support structures to be able to afford cycles 2, 3, and 4. So real life is where the Nigerian patient gets stuck. And this is very important because the science is not the problem. The delivery really is. I've had the privilege of delivering theranostics across 3 countries and 2 continents. And I can tell you that the radioligand behaves the same everywhere. Heidelberg is where this was first discovered. It behaves the same in Ibadan, the way it behaves in Heidelberg. What is different is not the science. What is different is the delivery. And this is why I really want you to stick around for the second part of the talk from Dr. Orunmuyi, how we can make this work. Right after that talk, I'll be coming back to tell you how this translates into clinical practice and what we've seen in our last 16 months of delivery. Thank you very much.
Thank you so much, Dr. Kolade. Dr. Orunmuyi?
Yes, thank you so much. Can you see my screen in full presentation mode?
No.
Yes. How about now?
Now, yes.
Okay. So thank you. My name is Akintunde Orunmuyi. Happy to be here and grateful for the opportunity to do this, not just for Nigeria, but for most of sub-Saharan Africa. And thank you, Mayowa, for showing us why it works. and I have no conflict of interest. I have tried to make this as simple as possible, and over the next couple of minutes, I'll be explaining how it works. There's something we have to remember from the science is that these radioactive sources, they have a time frame. We call them a half-life. Think of it like you go to the shops and you buy something, it has an expiry date. But the expiry date on these products are hours, some of them days. And that's what makes it unique. Most of them are produced in a cyclotron, in a reactor, and can be shipped from country to country. So in the UK where I work, we ship sometimes from Italy, sometimes from Norway, radioligand treatment doses. For the diagnostic aspects, some of them can be produced locally from a generator, and then some of them can be produced from a cyclotron. Fortunately, Nigeria has 1 or 2 cyclotrons and a couple more in the pipelines. But compared to London alone has perhaps 6, 7 cyclotrons. So just to have an idea of how important this is. So we can remember radiotheranostics, as Mayowa said, is the diagnostics and treatment combined together. But to make it easier, there's something called radioligand treatment, which describes the same thing because the treatment is a process. And we can remember that readily with RLT. And as Mayowa pointed out, the science is universal, the delivery is global. The challenges in sub-Saharan Africa boil down to resources, logistics, and sometimes the team. So when we talk about resources, we're speaking to spaces, what kind of spaces are required, the imaging support, because we have to find or identify disease that can be treated, the targets, before we give the treatment. So we never give lutetium without doing the imaging. And the labeling to attach the ligand to the radionuclide and to make sure it all stays together with the chelator, that requires a bit of radiopharmacy capability. Now, this is not rocket science. It's something that Oncidium Foundation has helped countries to label and to understand to do this safely. And then the logistics has to do with isotope supply, where it comes from. Every country has their customs regulation. Some customs regulation in some parts of Africa are a bit dated. So the concept of clearing something within hours is still a bit, is still evolving, I'll say that, and can be quite different even with the same country. So for example, Ibadan might be able to clear things quicker because they clear through Lagos, whereas Abuja or Kano might have difficulties clearing through another airport. But because of the short half-life, these things are delivered, and as they say in private practice, custom made for the patient. So it's tailored to the patient and depends on a reliable supply and delivery plan. And the team involves physicians, medical physicists, nuclear medicine physicians, medical physicists, then the radiopharmacy expertise, techs and the nurses, and they all have different aspects of this treatment where they come in and can transform the experience for the patient. That does not downplay the multidisciplinary planning that goes into it from the oncologist, from the urologist, and other members of the team. So if you remember resources, logistics, and the team, that's how we make it work. The other supporting structures are the regulation and governance. So each country has a different or has its own unique jurisdiction for these things. And the jurisdiction basically prescribes the standards at which it's done. So for example, in the global West, there's something called GMP, good manufacturing practice, because it's the pharmaceutical agent. The jurisdiction has raised the quality or the standards to GMP practice. But in other countries that are quite developed, they also have alternative alternative, I'll say resources or alternative ways to achieve the same thing. So without having a hot cell, you can use a laminar airflow, which creates the same sterility requirements as a GMP facility, but it's not as expensive and is also acceptable even up to clinical trial standards for some indications. So the facilities have to be licensed, the personnel have to be trained and accredited, the governance and accountability systems have to be documented. So it's not something that one person just has in his head. Prone to failure, but with a plan in place, it doesn't fail. But we still have to have that incident management documented as a standard protocol. As Mayowa said, the science is the same. And if you can deliver it safely, it is the same treatment, whether you travel to the US or you have it in Ibadan. The training is what we are trying to standardize. And do not take it for granted that someone in the US will come to Nigeria and will fit in perfectly, because the systems are slightly different. So the training has to be tailor-made and homegrown, preferably adapted to your local scenario. There are ideas around task shifting where a pharmacist can do some jobs that will otherwise be done by a nurse or vice versa. Sometimes nurses can lead the clinics and be the first point of call for the patient. Sometimes technologists can be trained, just like you have radiotherapy technologists who actually administer the treatment on the LINAC. You can also train technologists to do this safely. What's perhaps unique is the dosimetry. So everything is tailor-made to the patient. One needs to have a system for dose calibration, post-therapy imaging where appropriate. And that's why it's so important that we just don't roll out these things because it's fancy, but we have to make sure that all these elements for success are present. And it's usually patient specific. Now, how do we select the right patient? Mayowa has talked about imaging, but very quickly, if I show you this red box up here, it shows the trials that led us to where we are. So Vision trial was where PSMA, lutetium PSMA was used. I focused on PSMA as an example because PRRT is quite established. But the Vision trial, lutetium was used after chemotherapy in patients who had progressed on chemotherapy and was a late line or late treatment intervention, but still provided progression, improved outcome, overall survival, 15 to 19 months. But subsequent trials like therapy, PSMA4, PSMA addition have shown strong evidence that bringing lutetium earlier in the disease process can achieve better results with fewer side effects. So imaging plays the role for identifying patients with PSMA positive disease. Someone may ask how positive. It has to be intense uptake. It has to be large enough. So a patient with very tiny focus or multiple but small lesions, even though it's PSMA avid, may not be the best patient for lutetium. Now with actinium and the newer radioligands or radioactive tracers, we might be able to create treatment for those patients. If the patient has come very late, bone marrow is already down, platelets is low, hemoglobin is low, then it becomes a challenge. But the evolving evidence tells us that the treatment with lutetium is much more favorable because it has fewer side effects, fewer systemic side effects. So now the MDT plays a big role because there's now more choice. Basically, we're spot for choice in what to treat the patient with. We know patients can receive ADT, which is usually the first line of treatment, but the side effects of bone loss, muscle loss, and then the rise in metabolic disease or CVD risk affects, patients are becoming more aware and they're like, oh no, I don't want this. And it's amazing that even elderly men in their late 60s and 70s still want to have and want to preserve their sex. What else can different patients will have different tolerance to chemotherapy, but side effects are usually systematic or systemic. Neuropathy, marrow reserve can also be depleted with chemotherapy. And then now the patient is becoming more, or treatment is becoming more patient-centered. So the patient wants symptoms to go away. Patients want something that gives a good PSA response. So the PSA goes down. They want to maintain or improve their quality of life. And then there's also the aspect of treatment burden, who can help and support. So this tells us that even though it's now approved, the MDT helps to decide who's best to receive this and who's most likely to benefit from this. Now, coming home to sub-Saharan Africa, using Nigeria as a pilot or a case study, many patients are coming to know about it through meetings like this. So we're identifying that we need to increase access both among oncologists and urologists, and then the patients as well. And then there's rising access to imaging, which can be PSMA, PET-based, or SPECT, which is a useful alternative for identifying treatment candidates. And then access. Oncidium has played a significant role globally in improving access for countries where there is no reimbursement. So currently in sub-Saharan Africa, maybe apart from Kenya, not many countries have reimbursement or health insurance that covers theranostics. And then treatment, we need more centers to be able to provide this treatment. So some centers will provide as much as 10 treatments a day. Dr. Kolade will tell us more about his experience from the US, where they probably do a lot more. But, just to point out what's possible, we can do lots of patients in a day's job, and then the follow-up. So what's unique to here, we have Oncidium playing a role around access, but we also need to better identify where and how patients fall off. We need to be able to connect the referral pathways, improve diagnostic access. We need to partner with everyone. So this is a call to greater collaboration and partnerships. And sometimes those partnerships can be commercial. They could also be research partnerships. And then we need to enable the finance frameworks, the workforce training frameworks, local capability. So I could just talk briefly about ACT now. It's something that has or is evolving to try and identify and connect with local countries that recognizes the challenges locally. So with this, I've been able to show you how to make it work. It's not just small pockets of efforts in different places, but I think it would be nice to see teams come together, geographical collaboration, cross-country collaboration, if possible, to make this happen. Thank you once again for the opportunity. It's now time to focus on sub-Saharan Africa.
Amazing. Thank you, Dr. Akin. Dr. Kolade,
All
you have
right.
the
Thank you
next
so much,
10,
Dr.
15
Orunmuyi.
minutes.
All right. Thank you very much. That was excellent and so clear. And now you've seen the science, you've seen the infrastructure and what it takes to make it work in real life. Now let's see what it translates to by the patient's bedside. We're going to see what happened across the globe, what's happened in UCH, especially in the last 15 months, and a few patient stories that I want us to learn. Dr. Remy spoke about this very quickly, so I wouldn't rehash that. But what I want you to note is that in each of these pockets, before chemotherapy or after chemotherapy, what's important is this part of the story, and is that in patients who had maxed out on all their options, lutetium provided benefit. That's what the VISION trial says. In patients who could pick between cabazitaxel and lutetium PSMA had much more benefit in terms of reducing their PSAs, much better tolerability. In as regards bringing lutetium PSMA before chemotherapy and before ADT change, it also had benefits. So this is very clear and standard. However, what a time for Oncidium to choose to fix this summit, because literally between when the advert came out for this summit and today, a new indication had come out, literally the 31st of July. And that's the PSMA addition trial, where now PSMA has been moved from something that's left for patients who are end of the line and brought all the way forward. Yes, oncologists in the house, you heard me right. Now patients can be on ADT and lutetium PSMA, and this is FDA approved. So patients with hormone-sensitive prostate cancer with metastases are eligible for lutetium PSMA. This is exciting, but it's also very... The word I would say is weightily wonderful. It's wonderful, but it's very weighty. And why it's weighty is because overnight, the patients eligible for lutetium PSMA have exploded, but our capacity hasn't exploded. Our capacity is the same. So essentially, every argument we've made in this meeting so far and the others we'll make have become much more urgent. In the last 12 days, they've become even more urgent. As regards the trials in the neuroendocrine tumor space, like Dr. Orunmuyi said, that's very well established. The benefits are undoubted. And in December last year, we added that to the therapeutic offerings we give. So yes, you've heard that right, oncologists in the house. Lutetium dotatate is available in Nigeria. We've given about 8 doses so far across 3 patients. So there are different stages of their journey. So for us in UCH, like the protocols are across the globe, when we accept patients for therapy are when patients have PSMA-avid disease on all their lesions. Why all their lesions? That's because sometimes disease can be very heterogeneous and there may be pockets of disease that do not behave like the rest. And in those patients, there would be no PSMA uptake, meaning you wouldn't see it. And you remember that what we see is what we treat. So if we don't see it, it means our treatment is not going to go there. So PSMA negative patients wouldn't benefit from this treatment. And, they're typically not the people we treat. They must have a good functional status, have good blood reserve, good, that's bone marrow reserve, essentially, good kidney function. And the logistics, like Dr. Orunmuyi has very clearly told us, have to be right. However, most of the time, these are not the areas where we have issues. Most of the time it's with cost, and I'll get to that later on. But in terms of safety, we are able to do this significantly well, not to toot our own horn, but here it's not just something that is aspirational, it's stuff that's measured. So the discharge limits for patients when they're done with radioligand therapy, the legal limits for us in Nigeria, as Dr. Iyobosa would tell us, the physicists who are the vanguards of this, is 25 microsieverts per hour at 1 meter. And for all our patients measured, the median is about 7.8. So they are safe enough to go back into the community after being treated. Essentially, this translates to the fact that lutetium-177 PSMA can be given on outpatient basis. And we've practiced that in UCH with documented evidence to show patients are treated with shielded administration canisters. The exposure rates at the time of discharge are safe. They're giving safety instructions. So this is done safely and, with boots on the ground. The things that go wrong many times are their bone marrow compromises. And like I said earlier, it's really with patients who have been heavily pretreated. So this is a pointer for us to refer the patients much earlier and not have them have failed other lines of therapy first, where the bone marrow reserve is largely consumed, and we are not able to give them the best we could have. Sometimes we even have to modify our doses based on their bone marrow toxicities. Salivary gland issues are there in the books, but in our experience here, we don't really have those so much. In terms of their kidney functions, we give renal protection for therapies with neuroendocrine tumors where the renal toxicity is much more. With our prostate cancer patients, we do not see that in our experience, and that's the same in many places across the world. In terms of nausea, many times, because we pre-warn our patients that it's a possibility, those of them who've had chemotherapy before are surprised that it's that mild, that is this the nausea you're talking about? That's almost like no nausea to them. So nausea is not really an issue, and we give standard anti-nausea medication, antiemetics in this circumstance. So it's very mild, very self-limiting. Like I hinted at before, we've so far given 37 doses in our past few months of radioligand therapy service, and routinely, so it's predictable, the timing is standard. And this is where I want to say a big thank you to Oncidium Foundation. 6 of those patients who otherwise would not have been able to afford it were 6 of those doses rather of patients who would not have been able to afford therapy have been made accessible by the very kind work that the Oncidium Foundation is doing. So we're very, very grateful for that. I just want to show us 2 patients very quickly. This is a 74-year-old gentleman whose prostate cancer dates back to about 2012. And then when robotic surgery was still largely in the research domain, he was able to access it, and he had robotic prostatectomy. Unfortunately, his PSA didn't drop, showing that disease was still present. And he subsequently went through the different lines of therapy up until chemotherapy. And even with that, his PSA continued to rise. So finally, he was on a medication that works around the male hormones, a more modern medication. And that brought his PSA quite low to about 0.1. But very quickly, he maxed out on that again. And PSA started to rise very quickly. So went from 0, undetectable really, to about 1 to 3 to 6 in a matter of weeks. Then he came for lutetium PSMA, and the scan showed that his disease was predominantly in some parts of his chest. After the first cycle of the lutetium PSMA, the PSA rose a little bit. And this is important because we counsel our patients that this can happen after cycle 1. So you don't abandon lutetium PSMA after cycle 1 because there can be a flare. But after that flare, his PSA tanked to essentially undetectable levels, and it's been that way now for he spoke with me about 3 days ago, and his PSAs are still excellently low. And this is what it looked like by the time therapy was done. So this is on the ground, it works. Another patient is a man in his mid-70s, late 70s actually, and his PSA was way up in the roof, 9,000 and something. His image essentially showed disease in literally every bone in his body. And after about 2 cycles, his PSA tanked to 106. And this is what it looked like right after. We're still expecting his most recent PSAs, which we expect to be even lower still. So these are 2 examples of patients who had essentially what we refer to as complete response. And this is not something that's atypical. This is something that we tend to see quite fairly in a PSMA therapy clinic. So it works. Now to the point that is the closest to my heart. Number 1 is the fact that most of our patients didn't come from UCH. They were not local. They came from across the region, some from as far away. Unfortunately, those who are not local may not be able to conceptualize how far these places are. But some people came from as far as Zamfara. That's the other end of the country to access this. A few weeks ago, we had a man in his 90s who had to travel across the region late at night to access this. So what is happening here in UCH is essentially not just a departmental clinic. It's national infrastructure, and I think it should be treated and protected as such. Again, we are happy and glad that we were accredited by these 2 international organizations. It's not vanity, it's just external validation that maybe we're doing things right. But this is not the part that I really am passionate about, is that these 37 patients that I've told you about are less than half of all the patients that have shown up for this therapy. Most of them will either access it so they can come, but they can't afford it. Or they can afford it, but the time is too short, and many times they end up passing away before they access therapy. Or for some, like the man who had to travel all through the night from a very far part of the country, these are the issues. So I call them my silent cohort, and this slide is in honor to them. Because for every patient we end up treating, at least 2 or 3 fall by the wayside. And this tells us that we have to change strategy. We have to change strategy because that funnel is too wide at the top to have just 37 people have come through so far. So patients have to be referred earlier because some patients come when it's literally too late. We also have to think about funding in terms of cycles and not just individual doses. And again, I'm grateful to the Oncidium Foundation because that was my initial hesitation, that if you come and help a patient with 1 dose, what happens to dose 2, 3, 4, 5, and maybe 6? But they've been very gracious to fund cycles. And that's how I want, and I know some policymakers are probably here. Those are the ways that, it will help for us to think. I think we cannot understand the gravity of what we don't measure. So I think we should have national registries of all those who qualify for therapy. So we would know how many people are really falling out of the funnel, not just the people who come to Dr. Kolade's service. And finally, I think that the exceptional work that's happening here in UCH with all the resource constraints, every member of that team is a hero. And some of them are on the call today. It's my face that is seen, but it's really a tribute to every single one of them who is doing the phenomenal work to make this possible. In Nigeria now, this is not a pilot. This is not a trial. This is routine available care every day, and it's because of the fantastic people there. So I think that the team should be preserved as a national infrastructure and funded as such. And of course, many more centers need to be built. We're happy that there's now a center in Lagos with private collaboration that lutetium PSMA and lutetium lutetium can be accessed, but that's still a drop in the ocean for 220 million people. Thank you very much.
Wow. Dr. Kolade, you have stirred up some thoughts and conversations, which is what this whole summit is supposed to do. Dr. Akin, can you please turn on your camera? We are moving into the Q&A session. Thank you both for simplifying the complexities of this whole, the science behind theranostics. So I'm just going to jump right into the questions. I have some questions for you. I'm going to put you on the spot. You already know. Okay, so someone is asking, is lutetium 177 PSMA radio-labeled in-house at UCH, or was it shipped?
Thank you very much for that fantastic question.
Yeah.
There are components of it that have to be imported. And that's why it's very vulnerable to the exchange rate and very vulnerable to Forex fluctuations. But the phenomenal team of radiopharmacists are able to label this locally. And they've done this repeatedly 37 times. So yes, it's labeled in-house, but their components, the radioactive component, is imported. I hope I answered that.
Okay. Yes, you did. So someone is asking, therapeutic use of radiotheranostics, is it for curative, treatment purpose, palliative, or adjuvant therapy?
You've asked a fantastic question. Okay, let me allow if
I'll go.
Okay.
Yeah, I'm typing actually, trying to answer online.
All right, thank you, sir. You've asked a fantastic question. What would be the standard answer is to say it's palliative, because the real aim is to improve quality of life. There are patients who will tell you that they've slept well for the first time in a long time. So in that sense, it's palliative. But what do you say about the patient whose PSAs have been undetectable since December? Is it palliative, or is there a paradigm for patients where we can significantly roll back disease? Now, I wouldn't call it curative. No, not at all. We only speak about cure in prostate cancer when it's still in the prostate gland, where radical surgery or radical radiation come on board. So because of that, we're talking about improving quality of life, prolonging the patient's survival, prolonging progression of the disease. But we see in men of African descent that we're able to roll back disease significantly. But now, let me ask a question. In a patient who is in terrible pain and a patient who is not able to have a meaningful life, that patient is not really concerned about the classifications we give. He just wants his life back. So I am very careful about not just putting the bucket of saying it's palliative, which is what would be the standard answer. But I think there are deeper questions for us to interrogate as we go along. That's how I would answer it.
All right. Thank you very much. I can see Dr. Akin's already responding to some questions, so that makes my job easy. Somebody asks, does this PSMA therapy work for other cancers or mostly endocrine, PSA, and thyroid? I think maybe the lutetium is what he wants to add because PSMA is prostate specific already. So radiotheranostics, I believe, can we treat other cancers, apart from prostate? Maybe I'll allow Dr. Akin to speak now.
Thank you. So the cancers that we target most effectively with theranostics are cancers that are homogeneous. So they tend to behave in a similar way. Most cancers or some cancers are quite heterogeneous. So if you take 10 patients with breast cancer, they may all have different types of cancers, as opposed to prostate cancer, where maybe 9 out of 10 or 8 out of 10 would be prostatic adenocarcinoma, and others would be other types. So for tumors like thyroid, neuroendocrine, prostate, these are well-defined, established roles for theranostics. However, some other diseases are more common in our part of the world. For example, triple-negative breast cancer in young females. And because that's not a research focus for the global West, it's an opportunity to find tracers or targets that we can label these radioactive substances to diagnose and to treat. So, for example, there are some labels that look at HER2 receptor expression and can label and even mimic the histopathology in terms of identifying HER2 expression just by imaging. And subsequently, tracers like FAP have been targeted for breast cancer, and the pictures are remarkable. I'm sure in the next, when we look at the global perspective, we'll find studies that have been done in other parts of the world that showcase this. So yeah, I think it's something exciting that we can look forward to.
Okay, thank you very much. So the both of you now, like I said, Dr. Akin, you have experience of working here in Nigeria before you went, so you know the situation here. Dr. Kolade, we are in it together here. Dr. Akin left us. Let me just summarize. I can see issues coming up in the chat, people asking about training. This is a very interesting field. I was telling someone that radiotheranostics is the future of cancer care, so you better jump on board before you're left behind. So how can we make this accessible? We are talking about patients. I'm going to come to the patients now, but for the personnel who are the heroes now, how can we expand, training opportunities or create awareness amongst us, because, for example, let me talk about physics now. There are very, very few physicists in nuclear medicine. Everybody's in radiotherapy. So, but I'm sure people will be willing to come in if they knew how, to come in, if there were training opportunities. Is it something that we can work together on CDM Foundation, NAM, Medicaid? Does my question make sense? You can just, sorry, because
I will
we need
go first
personnel to do the
so that
work.
I can set
Yeah.
up Dr. Kolade before he
All right,
sets me
great.
up. So interestingly, while I was a resident as far back as 2014, we had done some of these radioligand treatments in South Africa. So it's getting old now, and it's about time that we put in those structures to facilitate training. Not everybody will get the opportunity to go to South Africa or even come to Southampton, where we have a very great center. But if we can, what we are thinking of is to have people with the experience within the continent to come and create local programs. And the idea is not to reproduce something from the US here, which would be quite difficult to do, but to see how we can make things work. And Dr. Kolade has done a lot in that regard. So while I was still with them in Nigeria, the only vision I have on my claim to fame is that as far back as 2011, I said this thing will grow. So we expanded our theranostics service from 2 beds to 10, 12. I don't know how much they have now, but that was the only foresight thing. So it's about future-proofing the service. we can train people, but the benefit of training should also be tied to service. So it took so long and so much passion for us to stay. I was growing old, so that's why I left, to put the training we have to application. But Dr. Kolade and Dr. Iyobosa, you guys are now, you've taken the baton and you
You
should
dumped
tell
it
us,
for us.
yes, tell us how you're going to make this happen. But there's so many resources on Obsidian Foundation, and many of us, our hearts are still back at home. So we're happy to come virtual. I think a lot of virtual training first, and then physical trainings once we establish the system. That would be the way.
Thank you. Dr. Kolade, do you want to add on? Should I ask my next question?
I agree with Dr. Orunmuyi 101%. And if you ask me, I think when you are building a structure, you lay foundation and you put blocks on top of that. It probably is not the smartest thing to do to buy roofing sheets at the beginning of construction when you don't have a foundation. So foundations have been laid and things are being built on them. If you ask me now, what I think we should do, and I hinted at it, and I hope that policymakers are here and listening, is to strengthen anchor centers such that UCH Ibadan now, if government is able to put 1, 2, 3 hot cells, you'll be amazed at what we'll be able to do. Put 2, 3 cameras, you'll be shocked at what we can produce. And that becomes an anchor center. And then other facilities can come there, rotate through there for training, so that we don't have to export training. The radiopharmacists in UCH can train you to label anything. They can label me with lutetium, and I'll carry lutetium on my head. Fantastic people. The nurses there can handle the worst patients ever. The physicists there see radiation with their bare eyes. So here's my point. Strengthen what's there. Hot cells, spec CTs, of course,
Infrastructure,
training,
basically.
yes, infrastructure, training for persons here and there, but strengthen it as an anchor center. And then the domino effect would be out of this world. So I think that's what we should do. And I think Obsidian Foundation, this is a fantastic opportunity to really stamp their thumbprint in the sands of time. And with the links they have with the IAEA now, a lot can happen. A lot is possible. So we can strengthen what exists to train what will be next. Thank you.
Excellent. Thank you. Speaking of Obsidian, Dr. Alice, who is the scientific director, wants to make a comment on what we are just talking about. Dr. Alice.
Hi, Alice.
Hi,
Hello.
Alice.
Thank
How are
you very
you?
much for this fantastic talk. I'm on vacation, so sorry.
Nice.
I'm a little bit not very informal here. I just want to point out what Dr. Mayowa just said, that Obsidian is here to support the implementation of radioligand therapy in hospitals. And of course, collaborating with the specialists such as Dr. Mayowa and his team, Dr. Akin, and also AIEA. So this is a very important collaboration that we have. And thank you very much for starting this virtual summit that is already a success. Looking forward to the next 2 ones.
Thank you so much, Dr. Alice. I can see some other questions because of our time. Some questions are related to infrastructure, government, and the rest. And the next 2 sessions are going to address those questions. So I would like to encourage every one of us, all 160 of us on the call, to please join us next week and the week after, where we will further discuss these issues that have been raised. So next week, we have the second webinar. We're looking at global perspectives, lessons from health systems that have already implemented radiotheranostics and what they mean for the region. And the week after, we would discuss further on infrastructure, training, and implementation in Nigeria. This is not a Nigerian meeting alone, but we believe, Nigeria is the largest country in Africa and very influential. So if we can sort things out here, I believe that other countries around us will be able to learn from us. So please join us in the next 2 sessions. The registration is free. You can please scan the code on your screen. And if you have other questions, please send an email to Medicaid Foundation, who is the partner, the second partner, second organizer of this wonderful summit, send an email to communications@medicaidcancerfoundation.org. If you have further questions, and also to request for your certificate of attendance. Dr. Akina, may I ask, Dr. Akina and Dr. Kolade, may I ask that you still look at the chat and answer a few questions there, if you can please answer.
I've been looking at the chats. I'm pleasantly surprised we have people from NIAC. And they're saying, what's the cost? Yes, I think we should actually bring them to present on the next one to tell us what they're doing to support, because they go for all the IAEA meetings, and there's some nice liaison we can do with them. There's a question from Professor Oloyede. What we're doing now is also advocacy. Okay, it's a comment. Thank you very much. And then there are lots of questions around training. Just to say it succinctly, is if you knew this training was available in Ibadan, it's probably easier to come to Ibadan and have the training. And I'm sure we can organize some form of training, a workshop, a hands-on workshop, where people come in to learn these things and see them. When the service expands, then that training is not in vain, because if you don't use training in a couple of months, then you also need retraining. So we can get support from commercial partnerships or research partnerships to strengthen the service. So to specifically say how much is the cost, it's probably, so in the US is about $40,000 per injection. Nigeria, through the efforts of, I was going to say through the efforts of Dr. Kolade and Oncidium, we've got it quite close to about 7,000. And once the service grows, I think it can even be more affordable. And it's not so scary because people are paying almost as much for chemotherapy. So for something that has a preferable side effect profile, I think the first hurdle is what we are doing, creating the awareness, establishing the safety and the standards, and then subsequently it can grow. So we need the help of policymakers, government, in terms of the biggest cost is duty and clearing from customs. If we can just get the systems to work, and over time we can find the incentives for custom to do better, for the clearing to be quicker. If government can waive some of the duties, because duty in Nigeria is about 30%, and that cost is borne by the patient. So I think in terms of training, it would be good to have some training locally. Again, if you're going internationally for training, you have to think about, if you come back and there's nothing to do, then sometimes mentally that's a bit difficult for some people. Dr. Kolade?
Thank you so much, sir. I would want to use the remaining breath of my last few comments to not put all the pressure on Oncidium Foundation, but Medicaid Foundation, because they have quite some experience with diagnostic centers and imaging. Medicaid Foundation would be doing the greatest good for radioligand therapy if they bought one SPECT CT for UCH. Just one SPECT CT. I can tell you, because the phenomenal radiographers we have on our team, they took a camera that was supposed to be
end of life,
over 10 years old, end of life. Essentially, this camera didn't have lutetium on it, and they created the energy window for lutetium. When I tell you that our team is phenomenal, they deserve all the flowers. So see what our radiographers did with a camera that should be end of life. Imagine they got a SPECT CT. So that's what my last comment would be Medicaid. Here is a platform to transform radiotheranostics.
Invest in. Yeah.
Just one SPECT CT for UCH, and you'll be amazed at what will come out of it. Thank you.
I can see the Excellency, Dr. Zainab's comment. Exactly.
Your Excellency, ma'am. Interestingly,
Medicaid has a hospital, for crying out loud. You should say they should buy their own hospital.
Interestingly, your Excellency, ma'am, there are very many ideas on how we can make this very viable. The truth is that lutetium so far has been sustained for these number of months because it was made to be viable and sustainable. Hand-me-outs they're not sustainable.
They're not
So
sustainable.
there are models by which this would do good and also make the investment worthwhile. So if Your Excellency is open to that, we have phenomenal thoughts on how this can kick off. So thank you very much.
Excellency, I say we'll sit and chat. Me, I'm in London. Oh, come to London and chat with me too. Anyway,
Thank you,
just
ma.
joking. Thank you,
Thank you
ma.
All
very
right.
That's
Thank you
really
so much. Thank
encouraging.
you, Your Excellency. Thank you. Thank you for highlighting Medicaid's role in all of this, because I was going to say that, it's a partnership. Oncidium, Medicaid, UCH, everyone, we all need to work together, right? So thank you, Oncidium, for organizing this. Thank you, Medicaid Foundation, for also organizing this. I don't know if they can turn on their camera so that people can see them. Tace and oh my God, what's this other name?
Dorian.
Gloria, I'm so sorry. Please.
Gloria,
Gloria, Aisha from Medicaid, please turn on your camera. These are the wonderful people that have been working for
Behind the
months.
scenes.
We've been planning all of this,
Phenomenal work.
Yes, so thank you so much. Please join us for week 2 and week 3, because we don't want to just talk. We want to come up with action items to implement a change, that we all need. The $7,000 Dr. Orunmuyi was looking at is dollars, $7,000. How many people can afford that? But I believe that if we put heads together, government, private, individuals like you and I, we can come up with something for the patients, for training of personnel. So thank you so much, everyone. They've stayed. We spent 8 minutes extra. We apologize for the time. Next week, we're going to keep the time. Thank you so much, everyone. Thank you, Dr.
Dr. Iyobosa, please, for those who were not here and want the recording, is there a way they can access it?
Yeah.
Okay, thank you.
Oncidium is going to provide it for us. They are
Fantastic.
fantastic people. They're going to do that.
Fantastic.
yeah, we will
So the
provide the
recordings will be
recording.
available. Yes, it's available, yes. And a certificate of attendance will also be available on request. So thank you, everyone. And we'll continue our discussion because I need to take them on some comments they made. Anyway, we'll do that behind the scenes. All right, so see you all next week. And
Thank you.
yeah, it's bye from my own end. Bye-bye, everyone.
Bye, everyone. Thank you
Thank
so
you.
much.
Bye.